All right, good morning. I would like to thank the conference organizers and the moderators for giving me the opportunity to speak this morning. I have no financial disclosures. I do have to disclose that I work in a super awesome lab though, and you got to hear from many of my wonderful lab mates this week. If you don't know my boss, Alex, he's an awesome individual, so please get to know him. All right, so I work at Nationwide Children's Hospital in the Institute for Genomic Medicine, and our mission and vision is to be able to combine a robust clinical laboratory with genome scientists and clinical geneticists to optimize patient care through the integration of molecular genomics and really making that the mainstream for our pediatric patient diagnosis and treatment. At the end of the day, we want to help these sick kids beat their cancer. And over the past few years at IGM, our monthly NGS case volume has continued to rise. In 2021, we saw an average of 139 cases a month. 2022, that bumped up to 313 cases a month. And from January to May so far this year, we've had an average of 555 cases a month. In tandem with consistent increase in this NGS case volume, the amount of genomics data and knowledge surrounding variants continues to greatly expand every year within our community. While we're able to perform assays like whole genome sequencing at an ever-increasing speed and decreased cost, the need to actually collect and evaluate all of that data regarding a variant by a human creates a bottleneck, such as was shown by the figure in Miriam's talk. Honestly, variant scientists and clinical directors are being asked to evaluate more data than ever before when they're analyzing these patient sequencing results, while also needing to actually ensure that the data regarding that variant is tied to the variant specifically as it's coming from disparate knowledge sources and making sure that that information is clinically pertinent. And while there's generally this increase in genomics data as a whole, there continues to be a dearth in the amount of pediatric-centric data that are found within these knowledge bases and resources that can actually be used during variant analysis. So how can we help our clinical teams through this variant analysis and evidence collection process while also developing a way to promote pediatric data sharing within our community? Well, at IGM, we decided to develop the variation categorizer, or VARCAT for short, to help alleviate this burden on our clinical team and create an open source platform for pediatric variant assessment sharing. So one of the main purposes of VARCAT is to severely reduce the manual searching and collation of variant data to help our clinical team spend less time on repetitive tasks and be able to focus more of their efforts on actually analyzing that data when it comes down to that variant. So through the MediCAB service, through the Variant Interpretation for Cancer Consortium, or VICC, and through some of the normalizers that my lab members have already spoken to this week, we're able to aggregate and harmonize data from many different sources and put those under a common data model that are then used for two of these clinical variation classification frameworks. The first being the ClinGen CGC VICC Oncogenicity Guidelines that Miriam briefly mentioned, and second being the AMP-ASCO-CAP Guidelines. So this harmonized data is presented through our VARCAT interface, so our users can go ahead and assess these variants under these specific frameworks, while also being able to manually add any pertinent evidence, such as PMIDs from journal articles, or anything else that's needed for the assessment. The data from the assessed variant is stored within a standardized format and can be automatically reused or reanalyzed when that same variant is seen again, while also tracking and retaining any changes that have been made historically to that assessment. Where possible, we've been able to build an automated pre-calculated code assignment for the oncogenicity SOP and automated AMP tiering classifications from evidence coming from databases such as CIVIC or Molecular Oncology Almanac, just to name a couple, for our clinical team to be able to review and edit if needed. Changes that are made to the automated classifications are captured for future analysis and potential improvements to VARCAT. We're actively expanding VARCAT's capabilities and really hope that as we continue to do this, we'll be able to also promote this common framework for pediatric data sharing. So for those of you who aren't as familiar with the oncogenicity guidelines, these are based on a Bayesian framework using this scoring system to determine the oncogenicity of a variant. The guidelines utilize data from many different sources, and if you're familiar at all with the 2015 ACMG guidelines, they're very closely related. So you'll see data like, population-based data or functional data and all of the above. And really, the oncogenicity guidelines are meant to do one thing, which is assess whether that variant is oncogenic or not. Can it cause cancer, right? So it sits in this space between variant annotation and clinical significance with your AMP-ASCO-CAP guidelines. So here's a screenshot of the VARCAT interface with the variant disease combo here being BRAF V600E and pilocytic astrocytoma. The first tab shown here is our oncogenicity guidelines tab, and you can see some of the data that would be potentially required to actually assess the oncogenicity of this variant. So we can see we have like cancer mutational hotspot data, whether this variant has been previously established as oncogenic, or in vitro and in vivo functional studies evidence, to name a few. And while we also have the ability within this tool we ask our users as they go through and assign a code to actually explain why they're doing so. So we ask for rationale. And within this, we also have the ability to upgrade and downgrade codes while again asking our users to explain why, right? So is there evidence that's not quite where we'd expect it to be and it maybe doesn't require a complete downgrade? We want to capture all this evidence so that this can be fed back to the community. As you can see in the red squares, these are areas that we're also able to auto-compute some of our codes. And while these guidelines are awesome and they've done a really good job, a couple of these codes are a little bit harder to apply within our clinical workflow, and oftentimes that really revolves around this term well-established. So let's take an example here. So this specific code, OM1, talks about whether that variant lies within a critical and well-established part of a functional domain. So let's actually table the part of a functional domain right now and just look at the entirety of the whole domain. So here we're looking at the gene PIK3R1 using the Cosmic Viewer, which is using PFAM as its protein domain track. And we're assessing this variant within the inter-SH2 domain, which actually we know causes binding issues between PIK3R1 and PIK3CA, which we all know is bad, right? So if we're using this viewer, we see this track, we're able to potentially assign this code. However, if you'd been using UniProt to actually assess the gene PIK3R1 to check for that variant, this would not actually be applicable because UniProt does not annotate this domain, which is kind of a bummer. Similarly, if you're using CBioPortal, and let's throw a wrench here, CBioPortal also uses PFAM, but a different version. We have considered you'd actually also not be able to apply this because that domain, again, is not annotated. So we've considered using a majority classifier by looking at a bunch of different protein domain tracks and then taking the majority result, but this is still going to require a bunch of manual effort to ensure that the majority classifier is in fact not wrong. Another thing that we're considering just in general as applying this code is just utilizing whether it lies in a protein domain at all and not trying to focus on a part of that functional domain, and just kind of dropping the well-established clause right now until we can get increased guidance on what that really requires. So now let's shift to in vitro and in vivo functional studies. So internally, what we've decided to do is just to continue to use the SOP that we developed when assessing functional data for the ACMG guidelines, right? And so for us, that requires us to judge applicability, validity, and validation of studies. Under each of these categories, we have our own internal SOP to judge these metrics. And while this allows for consistency within our lab, other institutions or labs might not actually follow the exact same criteria as us, which is not a good thing when we're trying to promote open source data sharing and make sure that we're all being consistent. So for an example, something that we're looking at doing is how to actually apply multiplex assay for variant effect data as functional evidence within our clinical workflow. So we're actively working with members of the AVE Alliance to calibrate MAVE data for use as clinical functional evidence, and that's not something that's mentioned at all within these guidelines. And while the ClinGen somatic team is doing an absolutely phenomenal job at tweaking these guidelines for specific genes, which we'll hear a little bit about from Jason Saliba next, it's also really important that as a community, we develop clear and explicit broad guidelines as well so that we can allow for confident use of cross-institutional evidence and assessments to enable the best quality of care for our patients. So how can VARCAT help us do this, right? VARCAT provides this framework for capturing data on things like what constitutes well-established as selected by our actual users, right? We can capture the rationale for code assignment that's being done through this manual expert assessment. And this data can then be fed back to the community so that we can work on updating the guidelines with objective constraints for applying the evidence and to allow for the promotion of the evolution of codes to enable more consistent application of these guidelines within a clinical setting. This cycle we refer to as the virtuous cycle, and this will allow us to continually to improve as a community. And then, again, with all of these and having this standardized framework, we can have the ability to promote open source sharing of pediatric cancer assessments to ensure the best quality of care, especially when it comes to rare pediatric cancer. So, speaking of getting community feedback, we had our annual 2023 hackathon on Saturday. Many of you in this room actually attended that, and it was wonderful. We had 5 different hackathon groups there, one of which was applying the ClinGen CGC VICC Oncogenicity Guidelines within a clinical workflow, and we had an awesome discussion. I have over 5 pages of notes that I have to distill through. The other topics that were discussed and worked on were things like civic molecular profile integration with OpenCravat, which OpenCravat was talked a little bit by Miriam, expanding the civic data model to include non-gene-based variants, the return of interpretation results to clinicians, how to actually use high-throughput functional assay data for variant interpretation. We would love it if you would join us next year at the hackathon. Don't worry, there's no programming skills required, so don't be turned off by the term hackathon. I would like to thank everyone on this list profusely. They are all wonderful. I would like to thank the NIH for the award that allows for this work to happen. If you could please do me a favor and scan the QR code at the top, there's 2 forms that I would really love for you to fill out. One being if you've tried using the ClinGen CGC Oncogenicity Guidelines, please provide me with initial feedback on that. 2, if you could provide me feedback on this talk, what I did well, what I didn't do well, and if you're interested in joining the hackathon, we would love to have you there. So please sign up. Thank you so much for your attention.